This is a classroom lecture that did not pick up audio, so I'm going to try to add audio here. I wanted to include the video from the classroom because I had visuals that I used. Visuals aren't always good in this particular class, but I'm going to try to include them and explain what I'm trying to demonstrate. The reason that the videos look different in different classes is because I teach out of separate classrooms. In the classroom where I teach positioning and basic physics, the desks are closer to the front of the room, and so I've got this very large field of view or very large magnified images, and I appear really close to the camera. On the days that I'm teaching image creation, the camera is a little bit further back and it's not quite so in your face. So the difficulty in providing those visuals is holding the things that I'm trying to demonstrate up high enough so that you can see them well. But I'm going to try to include those here and explain what it is I'm trying to show. So the difficulty that we have in imaging the femur is that the anatomy is so long that we can't fit it on an image receptor lengthwise. And where we could use the image receptor and place the anatomy on the image receptor from corner to corner in the tib fib, we don't have that luxury in the femur. And the reason for that is because in a femur, we've got anatomy that's thick enough that it creates a lot of scatter radiation. So scatter radiation increases as tissue thickness increases. And if we get to 10 centimeters or above, we need to utilize a grid to absorb some of that scatter radiation. Grids will be discussed later in the curriculum, but thick tissue, especially water-based tissues, create a lot of scatter radiation that emit from the patient, and they create fog on the image. And we got to get rid of that somehow or another. And how we do that is with a grid. So the grid is inside of the bucky. So the image receptor has to be not on tabletop underneath the patient's anatomy, but inside of the bucky so we can utilize a grid. So we don't have the luxury going corner to corner. As a result, what we're going to get is, because we have anatomy that's so long, and because of the divergence of the central ray, we have to extend our image receptor 2 inches below the knee to make sure we include the distal end, and 2 inches proximal to the hip so that we can get the proximal end. As a result, we can't really see both of those on most patients. So what we have to do then is to image either for the proximal end or the distal end, and the positioning for those two are going to be slightly different. So the AP femur for the distal end, what we're going to do is we're going to internally rotate the knee, and we're going to position like a knee without a central ray angulation, placing the femoral epicondyles parallel to the image receptor. The difficulty there, the problem there, is that when we do that, it's going to take the neck of the femur and it's going to put it at an angle to the image receptor. So that's what I'm trying to demonstrate here, is that with a knee position, or the femur position like a knee with femoral condyles parallel to the epicondyles parallel to the image receptor, the femoral neck is foreshortened. So we can't see both of them well on the same image. So even though we can't get both of them on the same image, we don't need to be trying to get both of them on the same image anyway. I'm going to pause here and I'm going to explain something. For the femur, most routines are going to call for an AP of the proximal and distal end, and then a lateral, both of the proximal and distal end. So it's 4 views for the femur, even though your requisition is probably only going to call for a 2-view femur, like an AP and lateral femur. It's really 2 APs and 2 laterals. You might work with a radiologist or an institution that will allow you to shoot an AP for one end and lateral for the opposite end, providing you have overlap between those 2 anatomies. If you work in an institution or for a radiologist that allows that, then what I highly recommend that you do is shoot the AP to include the proximal and a lateral to include the distal. The reason I say that is because the proximal end is very difficult it's much more difficult to get a good lateral on the proximal end than what it is on the distal end. Also, though, what you want to look for whenever your patient comes to you, if they're a trauma patient, is you want to look for telltale signs of fractures. Is there some sort of deformity present? is the leg rotated in an abnormal, unnatural way? If it is, then assume that you've got a fracture and don't move the patient's leg at all. So all the positioning, most of the positioning that we're going to talk about from this point forward is going to be assuming that the patient may not have a fracture. So if the patient doesn't have a fracture, you're not going to rotate the anatomy. But if they don't, if there's no evidence the patient has a fracture, then for the AP of the distal end, you're going to put the femoral condyles parallel to the image receptor. Unfortunately, that's going to put the neck at a different angle. But again, you're not going to be able to get both of them on there at the same time. For the proximal end, what we're going to do is we're going to internally rotate the patient's toes, and that's a demonstration of lateral. What we're going to do is we're going to internally rotate the patient's toes. And I noticed that there was a little bit of a difference. I mentioned this in class, and in the PowerPoints, there was a slight discrepancy between what is in the book and what is on the PowerPoints. So if I'm going to direct you to page 356. So it says to internally rotate the toes 15 to 20 degrees. In previous editions of the textbook, that was 10 to 15 degrees. And then if you look on page 381, it also says 15 to 20 degrees. So if you're using a previous edition of Merrill's, that previous edition would be before the 16th edition, you'll see a discrepancy or a difference between those. They've corrected it in this book, which is, I'm glad to see. So in both cases, what we're going to do, if it's AP projection of the femur, AP projection of the pelvis, or if you look on page 390, an AP projection of the hip. All three of those are going to say 15-degree internal rotation of the toes. And it's also important to understand that when you rotate, you want to instruct the patient to rotate from the hip. So that might mean that you have to put your hand directly above their knee and explain while you demonstrate. So internally rotate the toes. If you don't have them rotate from the hip and you're not specific to tell them to rotate from the hip, in a lot of cases they'll just point the toes inward, and most of that comes actually at the ankle. And again, you're going to have foreshortened femoral neck. So the AP of the proximal end, you're going to internally rotate the toes 15 to 20 degrees, and that's going to put the femoral neck parallel to the image receptor. And what you may see referred in registry review books, what reference you may see made is that overcomes the anteversion of the femoral neck. So just file that away somewhere in your mind, that if you see the word anteversion, that's specific to the hip. So you internally rotate the toes to keep from foreshortening the hip is kind of the short and long of it. So you get the AP, and if the patient doesn't have a fracture, then you're going to shoot a lateral. And the lateral of the hip, or the lateral of femur rather, is on page 358. And so again, what you're going to do is you're going to position a little bit different for proximal and distal end. If you're shooting for the distal end, then you can put the unaffected leg in front of the patient, like what you're seeing in figure 7.170. So put the unaffected leg, the upside leg, in front of the other one so that you can get the knee into a good lateral position. But if you're looking for the proximal end, then what you may have to do is oblique the patient just a little bit so that you can lay the patient's thigh on its side with the knee pretty much lateral without having the soft tissue and the bony structure of the pelvis and the opposite upper femora on top of the affected hip. So I kind of wasn't really paying a whole lot of attention to what I was dealing with in class when I was trying to make this demonstration, but what I had was a right femur trying to line it up with a left acetabulum. And I caught that. It'll show it here in just a second, but this bears a little bit of explanation. These two don't go together, and I don't mean right femur with left acetabulum, but if you look closely enough, you'll probably see a screw sticking out of this. So that screw means that this belongs on a different skeleton. These acetabulum don't have a place. This is just an axioskeleton. They don't have a place for this to attach. So what I'm trying to work off of is the shadow that this would be projecting. And with the shadow, I'm placing intentionally the femoral neck and head anterior to the acetabulum, trying to line the shadow up on the screen behind me. So I catch that I've got the wrong femur here, right about now, I think. Well, maybe not. At any rate, I'll figure it out here pretty quick. There it goes. All right. So what I'm trying to demonstrate here is that for the lateral, you can oblique the patient just a little bit. So what you're going to do is bend the patient's knee, externally rotate, and try to get the side of the femur in contact with the image receptor and parallel to the image receptor the best you can. So again, if you're going to shoot for the proximal end, then this is what you're going to want to do. You're going to want to oblique the patient just a little bit towards the image receptor, and then abduct and externally rotate the femur to try to make it as parallel to the image receptor as you possibly can. If you're shooting for the proximal end, internally rotate the toes 15 to 20 degrees. Yeah, so see, previous edition, which is where these slides came from, had a 10 to 15 degree angulation. I think these were from 2019, which would have put them in the previous edition. All right, so if you have a fracture, we're going to talk about that here in a bit, but if you can tell you've got a good lateral when you can't see the greater trochanter. It's going to be superimposed by the neck and the shaft of the femur, and I'll try to stop the recording when you can see that. So the shadow of it's pretty much gone. That's not perfect, but the shadow of it's pretty much gone. That's somewhat what a lateral proximal end should look like. It's also important to note that on the AP and the lateral both, you're never going to have a perfect knee, and that's because you're not shooting for the knee. You're not aligned to the knee, and the divergence of the central ray is going to carry the anatomy down into the joint space. So even if you position perfectly where the femur is lateral, you're not going to get a good lateral knee. You may not have rotation, but what you are going to have is projection of the medial epicondyle and condyle distal to the lateral. So you're never going to have good vertical alignment for the lateral as far as the knee goes. So we'll take a look at that image here in just a second and see what that looks like. So there's a good AP. You see the femoral neck without that foreshortening. You can see a little bit of the lesser trochanter, and you can see a good greater trochanter. So what we've got here is what we refer to as the intertrochanteric line. And that's the most common place for a hip fracture. So even though it's a femoral fracture, we refer to it as a hip fracture. And if you have a patient with an intertrochanteric hip fracture that's been repaired, what you're going to see is a great big fat screw, and it looks to be about the size of your thumb or maybe your pinky finger, and it's going all the way up into the patient, the head of the femur. And then you've got a plate that comes down on the outside of the femur with screws that go across to hold everything together. The other is what we refer to as a surgical neck or a femoral neck fracture. and that requires what we refer to as a percutaneous pinning. And with that, what you're going to see is 3 or 4 screws that come from the lateral side of the femur just below the greater trochanter, also all the way up into the head of the femur. And they should look like they're parallel to each other. And the reason that there's at least 3 is because geometrically the most sound structures are pyramids or triangular shaped things. So what they try to do is make them triangular. And there may be 4 so that what we have is kind of a triangle on top of an inverted triangle. So what we'll have is 1 screw, then we'll have 2 that are parallel to each other, then we'll have 1 screw on the bottom, so that the 1 screw on top and the 1 screw on bottom are kind of in the center between the 2 screws that are parallel to each other. But on the x-ray, being a 2-dimensional image, what you may see is, even though they have 4, 2 of them may be superimposed, and it may only look like there's 3 there. So that's perc pinning versus a full-on hip nail. So common fractures, we may have midshaft fractures, we may have femoral fractures that are midshaft, we may have proximal tibial fractures, which is what we're seeing here. Tib-fib fractures, distal end. Remember, most of your ankle fractures are actually distal tib-fib fractures, and they may be, may have a malleolus broken off, maybe a bimalleolar fracture. These are plates and screws. This is a little bitty rod that's going up into this patient's fibula. You don't see that very often. Most of the time, where we have intramedullary rods, they're going to be on the tibia, they're going to be on the femur or in the femur, or they're going to be in the humerus, but you just don't see them a whole lot in the fibula. So this is what we refer to as an external fixator. So if the bone is mushed up so much, common Judet fracture is so bad that they can't get a rod down in the bone without doing more damage to the bone, then they may use one of these. So this provides stability for the bone until it heals, and then they got to go in and take all these screws out and take that little erector set off of there. All right, so let you get a look at these. So proximal tibial fracture, this is actually an intramedullary rod. What they do with the intramedullary rod, or we'll refer to them as an IM rod, is they'll gain access to the, it may just be right below the tibial plateau, and they'll cut, bend the patient's knee up, and they'll cut through the skin, gain access to the bone, make a hole in the bone, and then they'll hollow out the medullary canal, and they'll drive this. First, they'll put a guide rod down in it, and then they'll drive this big rod over the guide wire. And once they get it into place, they'll put these screws. These screws actually go through the rod itself. And they'll put the screws in it to hold it in place, and it completely stabilizes the bone. So that bone, it's going to be tough to break that bone. They may, if they get in a bad enough injury, bad enough trauma, they may bend that bone, but I'm not sure I've ever seen an IM rod break. And this one on the left-hand side of the screen is kind of what a hip nail would look like if it was applied to a tibia. So you've got this long plate with the screws going across to stabilize it, but you generally have one big screw that goes almost all the way across. So those would be what we refer to as cortical screws, because they go all the way across the bone into the cortex on the other side. So hip and pelvis. Your hip bones, you've got 2 big bones that are broken down into other pieces that we're going to talk about, and we've got different names for them. So we've got os coxa, and then we've got the innominate bones, and that's referring to the entire pelvis minus the sacrum and coccyx. So each of those have 3 parts, and that is the ilium, which you're most familiar with. The iliac crest would be the top of the pelvis, and that's the big bone, the big flat bone. And then you've got the anterior pelvic bones, which are your ischium and your pubic bones. So those are down at the bottom, and they come together to form that hole in the bottom that we refer to as the obturator foramen. So all three of them form a portion of the acetabulum. So the acetabulum being the socket portion of the ball and socket joint. Well, I thought I had it broken down. The ilium and the ischium each form 2/5 of it, and the last fifth is formed by the pubic bone. Okay, so you have four prominent processes, and in anatomy, if you have something that is so specific it's named anterior, then naturally you're going to have posterior. If you have superior, you're going to have inferior. If you have anterior superior, you're going to have the exact opposite of that, being posterior inferior. And then if you're going to have posterior inferior, you're going to have posterior superior. If you have anterior superior, you'll naturally have anterior inferior. So the one of these that's most familiar to us is the anterior superior iliac spine, and we refer to that as the ASIS. The other three are worth noting. They may be registry testable. They are registry testable, so you might be familiar with them, but this is the only one that we're going to talk about regularly. So the superior margin of the os coxae, or the innominate bone, the ilium itself specifically, is the iliac crest. And then, of course, there's a greater sciatic notch on the posterior portion. So the ischium is kind of your, for lack of a better word, butt bone. So you've got the ischiotuberosity, and that's what you actually sit on. And then it forms a portion of the anterior pelvic bones, or the obturator foramen. So it's at the bottom of the obturator foramen, and then you've got the pubic bone, and it's also got a body of superior ramus, inferior ramus, and it forms again a fifth of the acetabulum, and it forms a portion of the obturator foramen, or the hole in the pelvis. Don't confuse obturator foramen for the acetabulum. So obturator foramen is here, acetabulum is there. Okay, so SI joints are the joints between the ilium and the sacrum. So I'm kind of trying to point those out, and they're where the two meet up. And a lot of people have arthritis issues in those areas. They do move a little bit. It's a gliding joint. It moves just a little bit, but it's fibrous, so it doesn't move just a whole lot. But if a patient has arthritis or issues in those, then they can do injections, just like what they do facet injections, lumbar injections, and things like that. So you might see this image on a test, and possibly all the way through the registry. You may see it referenced. Let me see if I can get an image with my hand out of the way. Okay, close enough. So what you've got is, in hip localization, is if you could draw an imaginary line from the ASIS to the superior border of the symphysis pubis, and if you would draw that line and bisect that line, meaning go right to the center of that line and then come off of it at a 90-degree angle, then the femoral head would be 1.5 inches down this line, and the neck would be 2.5 inches down that line. So they use this as reference as to where to put the central ray whenever we're doing hips, or whenever we're doing, if we need specialty views of the femoral head. What I tell my students is the easiest way to get a good hip or femur is to make sure that you have a patient on the table straight, and then put the longitudinal line of collimation coming straight down from the ASIS, and directly below that, what you're going to find is the femur. So if you put the top of your collimated field, pretty much, if your exam is for a hip, pretty much at the ASIS, or if you're doing a femur, maybe an inch above the ASIS, and have that longitudinal line of collimation going straight down the hip, you're going to hit the hip, or down the femur, you're going to hit the hip or the femur every time. I cannot stress enough how much I do not recommend that you palpate the symphysis pubis. I know we're professionals, but in the day and age that we're in right now, people are looking for reasons to be offended, and if you put your hand too low on their pelvis, it may lead to some problems, or it may lead to some uncomfortable situations for you as a technologist, as somebody may think that you're doing something that you should not be doing, or possibly they want you to do. So I don't recommend that. There are too many different ways to get to where you don't have to palpate the ASIS. So once we get into sacrum and coccyx, what you'll notice is that the distance between the symphysis pubis and the ASIS is pretty much 4 inches. So if you keep that in mind, anything that would call for you to put your central ray at the level of the symphysis pubis, you can just go 4 inches below the ASIS. Also, the symphysis pubis is pretty much at the same level as greater trochanter. So if you can palpate the greater trochanter, then you don't have to palpate the superior margin of the symphysis pubis. All right, so that's pretty much everything I just talked about. All right, so essential projections of the pelvis. So what we have with the pelvis, the most common is just the AP of the pelvis. So what you're going to utilize is a 14 by 17 collimated field. So you don't necessarily have to use your entire image receptor. 14 by 17 is going to be adequate for most patients. So 17 inches across, 14 inches lengthwise is your collimated field. And you can certainly go smaller than that if the patient's small. If the patient's very large, I don't know, if you have a 7-foot tall patient, you might use a slightly larger collimated field. So with your AP of the pelvis, you're going to internally rotate the toes again from the hip 15 to 20 degrees. Make sure that your ASIS is equidistant from the tabletop. So the 15 to 20 degrees internal rotation is to overcome the anteversion of the femoral neck, foreshortening of the femoral neck, and the ASIS equidistance from the tabletop ensures that you don't have rotation. So you're going to forget to internally rotate the toes at some point, and somebody's going to call you on it, or you may position and take a little bit too long, and the patient will relax their feet and externally rotate their toes. So if the image comes out and somebody says, yeah, you need to go back and repeat and shoot it with the toes internally rotated, there's only one thing that's going to give the appearance of the toes not being internally rotated, and that is the toes weren't internally rotated. All right, so that's what a pelvis should look like. Again, we've got good, we've got a good length on our femoral neck, is not foreshortened. It looks like we might have the slightest amount of rotation. It's not terrible, but a slight amount of rotation. All right, so Cleaves method, what we're going to talk about is modified Cleaves. And the original Cleaves calls for a cephalic central ray angulation. It's just not all that common. So a Cleaves method is, if you're looking at the 16th edition on page 386, you're looking at the Cleaves method. So Cleaves method is sometimes referred to as the frog leg. So you can do bilateral or you can do unilateral. And this is a view that we're going to do, or an exam that we're going to do if you know the patient doesn't have a hip fracture. So if a patient has a hip fracture, how they're going to come to you is rotated towards the anatomy of interest. So if their hip is potentially broken on the left-hand side, they're going to be rotated towards the left-hand side. Sooner or later, you're going to have to get the whatever's holding them in that position, usually pillows. You're going to have to pull the pillows out from under the patient and have them roll back flat if your order calls for a pelvis. If you roll the patient back flat and their foot on that affected side is externally rotated all the way up until it's on its side, then that's a good indication the patient has broken hip or potentially femur as well. So if both of those things exist, both of those potential positioning things exist, this is not what you're going to do for a lateral. Okay. But what you can do is, if you're doing a unilateral, then what you'll do is oblique the patient slightly towards the anatomy of interest, bend the patient's knee up about 45 degrees, and externally rotate it. Now you can take the collimator housing and you can turn it so that the lines more closely follow the anatomy, the femur specifically in this case. So that it parallels the femur. Or if you're doing bilateral, what you're going to do is you're going to bend both knees up 45 degrees. You're going to put their feet together and then externally rotate both of them in position, kind of like a low pelvis. So in this case, what we want is not necessarily the top of the iliac crest, but we want to see as much of the proximal femurs as possible. So modified cleaves would be, again, your frog leg. Bend the patient's knees, externally rotate both if it's truly a Cleaves. If it is a unilateral frog leg, then obviously it's just going to be one side, and you can rotate the patient slightly towards that side. Now we'll pause this here for a second and explain something. Okay, so the patient comes to you and they're already rotated up towards one side. Sometimes it's best to go ahead and shoot that as a lateral and get a look at that, maybe show it to a radiologist and see if they have any consideration or concerns that the patient has a fracture. And if they do, then you can certainly take the pillows out from under the patient and try to get them flat. But what you're not going to do is point the toes, internally rotate the toes. So in that way, you've kind of got your lateral, but not necessarily a true lateral. So if you flip over to page 390, you see positioning for the AP of the hip. So if your order calls for a hip, not a femur, again, the top of your image receptor should be at the ASIS, and then your longitudinal line of collimation should be going straight down the length of the femur, but only 12 inches. So the only difference between the AP of the hip and the AP of the proximal femur is central ray location collimation, and that's pretty much it. So what if your patient does have a broken hip? Well, then what you're going to have to do is what we refer to as the Donnellius-Miller method. Now, before I press on to Donnellius-Miller, if you look on page 392, you see another view that is essentially the same thing as a frog leg, and that is the Lowenstein and Hickey method. It's pretty much the same thing as a modified unilateral Cleaves method. So it's another frog leg. So the Donnellius-Miller, if you look on page 394, you will see what it is. So it's referred to as most commonly surgical lateral, and it is for a patient who has truly has a hip fracture, and you need to get a good lateral. So what you're going to do is a number of things. So you've got to do this tabletop. You need a grid because you're shooting through a lot of tissue. And what you're going to do is you're going to put the image receptor, you're going to try to imagine how the femoral neck is positioned inside of the patient's body. And you're going to try to put the image receptor parallel to the femoral neck. it needs to go above the iliac crest. So it's got to be pressed into the patient above the iliac crest, but below the angle of the ribs. And then you're going to put your central ray perpendicular to the image receptor, which should put it perpendicular also to the femoral neck. Now, what you're going to have to do, though, is elevate the unaffected leg and externally rotate. So you're seeing that on page 394, but the descriptions don't always, give you that extra step of externally rotating. So what the external rotation does is it takes the soft tissue of that unaffected leg and it rotates it out of the way. So that you're not shooting through more soft tissue. Remember, more soft tissue gives you more scatter radiation. So you're getting that soft tissue out of the way, and the only thing that you're left with is the soft tissue you cannot move out of the way. So if you look on page 395, you see the x-ray of surgical lateral Donnellius Miller, and it is it's pretty good. So that's about what you expect to see. Sometimes, it looks like they utilized a cone on this, but you probably should include just a little bit more femur, as your intertrochanteric hip fractures might have this, and then it may have a butterfly off of it. Butterfly just being another chip off of it. So pelvic fractures. Pelvic fractures can be kind of dangerous because you've got the internal and external iliacs that are running directly in front of the iliac wings. So good imaging of the pelvis and pelvic fractures is kind of difficult. We talked about the AP. Let's say we shot AP, we noticed the patient had what we refer to as vertical shear fracture or possibly anterior pelvic bone fractures. How we're going to image those in different planes. And the Judet method is one of the ways that we can do that. So if the patient's stable enough, or if you can strap them down to the backboard, I don't really recommend this, but you potentially could oblique the patient up. So what the Judet method is, as described on page 400, is bilateral obliques just for the acetabulum on a small collimated field. Collimated field just includes the individual acetabulum, so it's 10 by 12 collimated field. So if you look at the images on page 400, and I'm going to run this while I'm talking because I kind of described this. If you look at the images on page 400, what you'll see is that with the patient in LPO, the acetabulum on the elevated side is pretty much looking directly up at the x-ray tube. So the LPO shows us a frontal view of the elevated acetabulum. With the pelvis flat, if the patient's laying flat on their back, neither acetabulum is either, kind of AP or lateral. They're both at oblique. So with the LPO, we see the open, elevated right acetabulum. But if you look at image B on page 400, then what you see is in the RPO, that same acetabulum, we're looking at the right acetabulum in both of those, then we get a lateral view of it. So what we see is an open acetabulum on the elevated side, or kind of a frontal view of it, kind of an AP type thing, and then on the other oblique, so in this case it would be the RPO, we see a lateral. All right. So it's bilateral obliques, and what I mentioned in class on Monday is that every doctor I've ever worked with did not want us to use the 10 by 12 field size. What the doctor wanted us to do was to shoot it like a pelvis. And the reason for that is because with two obliques, an LPO and an RPO, what we'll be able to see is the entire pelvis. So if you're looking at the video, what you see is, let me stop it right there. So before I rotated it, both iliac wings were at an angle to the to the camera. All the anterior pelvic bones were also at an angle. So as I rotated this thing up, what happened is the downside iliac wing flattened out. So the upside iliac wing became more lateral. Okay, so not only am I getting a view of the acetabulum, but I'm also getting an AP and a lateral view of the opposite sides of the iliac wing. So the elevated iliac wing becomes more vertical, kind of like a lateral, and the side that's closest to the image receptor becomes more flattened out. We don't have that foreshortening. You can't really see the shadow of the anterior pelvic bones, but you will here in a minute. And what you'll see then is that the anterior pelvic bones on the, if you look at the side that's closest to my bottom hand, they're more vertical, and the ones that are furthest are more open. So I'm trying to demonstrate that here. So what we get then in the Judets is not just the acetabulum, but the anterior pelvic bones on the elevated side opened, and we get more of a frontal view. The side that's closest to the image receptor, we get a lateral. And then if we do the opposite oblique, then we get the exact opposite thing. So pause this a minute and looking back at the image that you're seeing on page 400. What you get in that LPO then is the open anterior pelvic bones for a frontal view of the anterior pelvic bones. You also get an open acetabulum for a frontal view of the acetabulum. You get a lateral of that right iliac wing. On the left-hand side, what you get is a lateral of the acetabulum. You get a lateral of the anterior pelvic bone, and you get more of a frontal view of the iliac wing. Now you reverse all that for the RPO. So on the RPO, what you get is the open anterior pelvic bones on the left-hand side, a open acetabulum on the elevated side. On the side closest to the image receptor, we get a lateral of the acetabulum. We get a lateral of the anterior pelvic bones, and we get a more frontal view of the pelvic bone, or the iliac wing on the side closest to the image receptor. It's more lateral on the left-hand side. So in two views, we can see AP and lateral of all of the pelvic bones. Now the problem with the Judet views are that it requires the patient to get into a 45-degree oblique. And if we have unstable fractures of the pelvis, then that could be problematic. So what we can do then, in order to not move the patient and to get two views at right angles from each other, or close to right angles from each other, is we can do this. So if you flip now in your textbook over to page 402, you see the Taylor method. And the Taylor method is also referred to as the outlet projection. So what we do with the Taylor method is we angle our central ray 20 to 35 degrees cephalic for men and 30 to 45 degrees cephalic for women. So the purpose in this is to put the central ray perpendicular to the anterior pelvic bone, so you see them like you're seeing on the video right now. So you can kind of see them. They're foreshortened in that they're not parallel to the image receptor. They kind of have that downward slope, but they're perpendicular to the way they would be angled from top to bottom. All right, so they're less foreshortened than what they would have otherwise been. So our likelihood of seeing a fracture of those anterior pelvic bones is much better, and we didn't have to oblique the patient in order to get it. So how do we get another view 90 degrees from that? And if you flip over to page 404, if we have an outlet view, then naturally we're going to have an inlet view. So this will be a superior-inferior axial projection. The outlet view was an inferior-superior axial projection. And so in this case, in both males and females, we're going to angle the central ray 40 degrees caudad. And what we're going to see then is the anterior pelvic bones all stacked on top of each other, right like that, so that we can see anterior to posterior displacement. And now we can tell, not only are there fractures, but where are those fractures going. So I hope this wasn't too weird. Video recorded in class, audio recorded at my desk, trying to remember what it was I talked about exactly in class. Sorry for the kind of mix up there. I had some extra equipment in the room that I had not expected to interfere with the recording, but it did. So hope this is helpful.